So hopefully you are reading the assigned readings before lecture. Okay, if you're not, you need to. That's why I put very specific page numbers in there for you to read before lecture. That way you've read it and then we go over it in lecture, because if you notice, I don't reference the book a whole lot, but there's a reason for that. You're supposed to have already read that, and then this is to reinforce that. So sometimes I'll have page numbers in the PowerPoint, but they're listed. I mean, the exact pages where you'll find this information are listed on the course outline. So make sure that you are looking at that. Let's see if this clicker is going to work. All right. So for today, we're going to look at kVp's relationship to receptor exposure and subject contrast, which we began to talk about last week. What is optimum kVp? Like, what does that mean? What is the 15% rule? We have more math, but it's really easy math this week. So applying the 15% rule to control subject contrast and still maintain receptor exposure. So as far as kVp, the function of kVp is to provide at least partial penetration through all tissues to be recorded. So in other words, we want the kVp to be high enough to penetrate through the thickest part of the part that you're looking at. So if it's an elbow, you want it thick enough to get through that thickest part of the elbow where that olecranon sits. Y'all be reviewing that as well this week. So some things that we already know to be true about kVp that we started talking about really week one and then really got into last week is that kVp controls the speed of the electrons from the cathode to the anode during the exposure. Now that is generally about half the speed of light, but that does vary based upon the kVp that we set at the control panel. So we know that the faster the speed of those electrons has a greater impact at the target. Okay, so the target meaning the anode. It has a higher X-ray photon energy that's created when that speed is increased, which means those photons are going to have more penetrating ability. They're going to be able to pass through the part easier. It also means that more scatter radiation is going to reach the IR, which is never a good thing. Scatter, we don't like when scatter reaches the IR because it degrades the quality of the image. It also means that there's going to be less absorption. So if there's a better chance that they're going to make it through, that means there's got to be a lesser chance for those photons to be absorbed in the patient's body, which means we get a more uniform exposure due to the decrease in differential absorption within the part. So remember, differential absorption is one of those definitions you've just got to know, and it basically just means that body parts absorb radiation differently, depending on their atomic number, their tissue density, the thickness of the part, all of those things. And when we have more uniform exposure across the part, then that means we're going to have lower subject contrast. So lower subject contrast, meaning that those areas are absorbing radiation very similarly. Okay, so there's going to be less difference in the brightness levels that we see. God bless you. So that's a good review and sort of summary page. This again is another image of, this is actually a real image of a penetrometer. The penetrometer is the step wedge, okay, that we used to use all the time for QC stuff. So you can see that the kVp has been changed from the left to the right. Which one of these images, left or right, had the highest kVp, and how do you know? Okay, so I hear left and right. So who wants to vote for left? Okay, so a couple, who's voting for right? Okay, so the rights have it, right? I did say higher kVp, right?
Mhm.
Okay. So how do we know that the image on the right, and the image quality is not super great, but how do we know that the image on the right was done with a higher kVp?
So it penetrated more.
Yeah, so it's more uniform, right? The image on the left, at the top of that image, we can see that that area was not penetrated well at all, right? Because if photons make it through to the IR, and a lot of photons make it through to the IR, is the brightness going to be really bright or less bright or darker? Darker, right? It's been exposed to more radiation, just like the marshmallow, when it's black, has been exposed to the fire longer. So, so the image on the left was done with a lower kVp. The image on the right was done with a higher kVp. Now, optimum kVp is that kVp that's going to penetrate the body part and produce a consistent level of scatter. So we know that there's going to be scatter that reaches the IR. That's just going to happen. That's a part of what we have to deal with when we're, making our decisions about our technique and whether or not we use a grid and that kind of stuff. Excuse me. But generally, we want to keep our kVp where it's producing a consistent level of scatter, a level that radiologists are used to seeing with whatever body part we're doing. So penetration of the part means that you can see the trabecular patterns of the bone in the area hardest to penetrate. So I actually gave this example earlier. For example, the elbow. So the penetration of the part through that thickest area or that most dense area, which in the case of the elbow is right through the path of the central ray. That's going to be the thickest, boniest part. So which of those images, left or right, was well penetrated? The left, because we can see through that thickest part. We can see through where the olecranon fossa is and where the olecranon sits in that very center part of the elbow joint. So one thing that we have to remember, and we're actually going to do this activity in the lab today, but no amount of mass can ever compensate for insufficient kVp. And we're going to see this in the lab. So it's sort of like Ethan gave this great example several years ago, and I've just continued to use this to help you understand what this is trying to say. It would be like if you had 1,000 soldiers, okay, you can relate to this because you're military. You have 1,000 soldiers, but they're all 90 to 100 years old, and they're fragile, and they're weak. Are they really going to do you a whole lot of good? Probably not. So it's the same thing with the photons. We can have 1,000 photons, but if none of them have the energy to get through the part, they're worthless to us. So that's what this is saying is if you do not have the kVp set high enough to penetrate through the part, then it's never going to be enough mass. You can just keep increasing the mass, increasing the mass, increasing the mass, and it's not going to change the quality of your image. Your image is still going to be underexposed because those photons are not making it through the body. Does that make sense? So we're actually going to do this with the skull. I know y'all haven't had skull, but there's a really good area that we can see it through your mastoids, through those bones that sit right behind your ear. So there's a good area right there that hopefully we can demonstrate this. Even though the computer software is going to try its best to correct and make it look right. It's going to try to adjust the brightness level so that it looks right. But hopefully you'll be able to see that. So again, optimum kVp. So when we think about the thorax can be radiographed to demonstrate several different things. We can be looking at the chest, the PA chest. We could also be interested in just the ribs or the APT spine. So you can see that in the same range of body, there's 3 different exams that we might do in this area of the body. And we're trying to see different things. So we're going to adjust the kVp based upon exactly which part of this area are we wanting to visualize the best. So you can see for PA chest, about 110 to 125 kVp, because we want sort of lower contrast. We want to be able to see through and be able to identify a lot of different shades of gray, so that we don't miss something small, like some kind of little nodule or something in the lungs. We want to be able to have a little bit lower contrast. So remember, I said low contrast is not a bad thing. It's just when contrast is lower because of scatter, then it's a bad thing. But just low contrast in general, sometimes we want to see, like in the chest. Ribs, we want that subject contrast to be a little higher, because we're looking specifically for the bones, right? The ribs. We want to see if there's any little subtle fractures in the ribs. So we're going to lower our kVp. Lowering our kVp to 60 to 65 does what to subject contrast? Does it go up or down? Yes, because it has what kind of relationship? Inverse, meaning if kVp goes up, subject contrast goes down. kVp goes down, subject contrast goes up. And then the T-spine is sort of in the middle. So generally for an APT spine, we're looking at about 75 to 80 kVp is adequate to get through the spine. Okay. So generally, within a given procedural series, the kVp should be kept fairly stable while the mass is adjusted for different projections. So what that's talking about is, in general, you'll have like kVp ranges, and you're going to see in your lab manual this week, I gave you a chart that just sort of gives you general kVp ranges for different body parts. And then as we change the thickness of the part, or that may be the pathology, if the patient has certain, pathological conditions, then we usually adjust the mass, okay, depending on that. The one exception, or of course there's probably more than this, but at least one exception to this is when we're talking about the lateral L5S1 spot. And so your lumbar spine, ends down here in your pelvis at your sacrum. So your L5, so your 5th lumbar and your 1st sacrum vertebral, I can't talk this morning, vertebral bodies. At that area, it sits right between the wings of your pelvis. So in the lateral projection, there's about 4 times the percentage of bone in that area than there is when we're talking about up here above the pelvis. So in that case, we actually do usually increase the kVp, because it's just harder to penetrate through that area because there's so much more bone in that area. Rather than, we always and you're going to do this today in lab as well, from the AP to the lateral, do you think you need more technique or less when you're going from the AP to the lateral on the lumbar, this area right here? More, because you're thicker this way, right? We're thicker this way than we are this way. So we're going to see today in lab, you're going to do a whole bunch of measurements with the calipers of one of your lab members. And that's just to help you get used to, knowing what 10 centimeters looks like. And then figuring out what we call minimum kVp. And we'll do that in lab. So when might you change the kVp? If you need additional penetration, like for a contrast study. So we started talking last week about contrast, when we give patients contrast, and that's to increase the subject contrast. It's to visualize parts that typically we couldn't see or wouldn't see if we don't give them some kind of contrast, whether that's depending on if it's a GI study where we're giving it to them to drink, or barium enemas, we're looking at the colon, or if we're looking at the Kidneys, we would give an intravenous injection just to highlight those areas so that you can see them. So that would be one time that we might need to add kVp or increase kVp because we've given the patient some barium to drink. If we want to adjust the subject contrast, and we just said how to do that, if we increase kVp, then that decreases subject contrast. Or in some instances, which is not real common, but if we're trying to help control motion, then we can, if we use a higher kVp, then we can use a lower mass, which means we could use a lower time, which would give us less chance of motion. So that is just a scenario that you could adjust kVp for, but are you going to see it done a lot? No, probably not. So optimum contrast, again, we said last week, we don't really, there's not like, we don't want it to be super high. We don't want it to be super low. We want it to be optimum so that we can see all the areas we're trying to see. So optimum contrast means each shade of gray is seen distinguishable from the next, and that it will demonstrate anatomy that would be lost on very high contrast images that are very black and white, or lost on very low contrast images that are just uniformly very gray. You really can't tell a difference between anything. So optimum is somewhere in between there. So just to review, or is this an intro? Let's see. I don't think we talked about this yet. Okay. So photoelectric effect. This is one of the, well, we've touched on it, but we hadn't really talked real specific about it. So we said that there's three things that can happen to a photon when it's directed at the patient, right? Photoelectric is one of them. That's the absorption piece of it. So, and this is actually from your book, and you can, I forget which page, I meant to put it on here. I want to say it's like 31, 32. If anybody has it, you can look. But anyway, this is directly from your book. So photoelectric effect is when the incident photon, meaning the photon that's directed at the patient, interacts with an inner shell electron and removes it. Okay, so you can see in the picture here, it says the incident, number one there, incident photon interacts with an inner orbital K or L electron, giving all of its energy to the electron, ejecting it from the orbit. That photon is absorbed. So photoelectric absorption. And then that ejected electron, the photoelectron, imparts the atom with energy equal to the excess of the electron's binding energy. So whatever energy was given off, that's what that photoelectron has. And that leaves a vacancy, right? And that leaves the atom what? Unstable. Yes, unstable. And so naturally, an electron from an outer shell is going to drop in that. It wants to fill that hole or that void. And so as the electron drops to the void, it may shed its excess energy as a secondary photon. And generally, those secondary photons, they're just absorbed because their energy is so low, they're basically absorbed as well into the patient's body. So photoelectric absorption is when the photon interacts with an inner shell electron, completely knocks it out, and then another electron falls in and it gives up all of its energy to do that. Okay, and so it's totally absorbed in the patient's body. So that's photoelectric. Compton effect or Compton scatter, that's the second thing that can happen when a photon is directed at a patient. So the photon interacts with an outer outer orbital electron and gives some of its energy to the electron, ejecting it from the orbit. And then that ejected electron leaves the atom with an energy equal to the excess impaired by the photon. So it leaves with less energy and in a different direction. Okay, and so it says the photon continues on an altered path, meaning a different direction, scattered with less energy than before the collision. So in photoelectric, the electron is ejected from the inner shell, and all of that energy is given off, and that photon is completely absorbed. With scatter, it interacts with the outer shell, so it gives off some of its energy, it changes direction, and if that scattered photon makes it to the IR, then that is what is degrading the quality of our image, because it's not an accurate representation, right? It's not going to give you an accurate representation of the anatomy. I believe today is also when we're going to do an activity in lab to demonstrate scatter and how the body is the main producer of the scatter. Now, scatter can be created in the table, or like if you're directing the, well, we'll talk about that. Never mind. We'll get to that. I don't want to get off track. So kVp and scatter radiation, the use of optimum kVp keeps scatter to a minimum and consistent, again, which is important when you're talking about the radiologist reading the images. Somewhat different from patient to patient, but it's predictable, okay? And it produces what we would call an acceptable amount of scatter. So we know that scatter is going to be a part of creating the image, and let's just keep that to a minimum, keep that to a level that the radiologists are happy about, because they're ultimately the ones who are having to read the images that we send. So here's where it can get a little convoluted for students. Okay, so we're going to try to talk through this and help you understand what's happening here. So scatter radiation, as kVp increases, the absolute number of any interactions happening decreases. So can we all say that we understand that? So if kVp goes up, the chance for any interaction at all over the board goes down, because what is there a greater chance is going to happen if kVp goes up?
Penetration.
Yes, it's going to penetrate through the part, it's going to transmit through the part, it's going to make it through the part without any interactions. Okay, overall, when we talk about increasing kVp, that's what's happening. The chance of any interaction at all goes down. Okay. The next part of this is where it can get a little tricky. So the reason for that is because the number of photoelectric interactions decreases much more rapidly. Therefore, the relative number of X-rays that undergo Compton scatter increases. So what this is saying is, even though overall, when we increase kVp, the chance of anything happening goes down. However, when we increase kVp, relative to those two interactions, meaning when we look at photoelectric compared to scatter is going to go up. Does that make sense? So when we're talking about overall, the chance of any interaction happening goes down. However, when we compare those two to one another, scatter is going to go up because photoelectric goes down so much quicker. Okay, so this next statement, he's very, this is from Quinn Carroll's book, and he's very, what's the term when you're very wordy? What's that word? It's gone out of my brain. Anyway. Okay.
Loquacious?
Maybe. So he's very smart. I've met him several times at different conferences, and his textbook is about yay thick. That's why I never get y'all to buy that book, because it is very comprehensive and it's a great reference. But when he says it's less to do with how much scatter is produced within the patient than it does with the precipitous decline and disappearance of photoelectric interactions at high kVps, whereby photoelectrics are no longer a part of the image information. Y'all see why we don't use this book? Okay, all he's saying there is that it's more to do with the fact that the chance for photoelectric goes down so much more rapidly is the reason that Compton scatter goes up when we increase kVp.
But why does the photoelectric one go down faster?
It just has to do with the atomic number of the part. So let's look at some more here. Hopefully, maybe this I hope this is not confusing. I hope this is actually helpful, but if you look at this breakdown, the first line up there, first row, says the percent of attenuation for every 1,000 photons in 10 centimeters of tissue. So first of all, let's back up and make sure that everybody remembers what attenuation is. So what is attenuation? What's the definition of attenuation?
Doesn't it have to do with contrast?
It affects contrast, but that's not.
The process of, what is it, an X-ray photon interacting with, I can't remember.
So it's a decrease in what? Overall what?
So
Photon absorption.
the person that gives it-
Intensity. Okay, so it's a decrease in intensity of the beam that's due to either Compton scatter or photoelectric. So when we talk about intensity in radiology world, what are we talking about? Quality or quantity? Quantity. So it's a decrease in the quantity of X-ray photons that make it through the part. All right. So attenuation means it's a loss of intensity, a loss of the number of photons making it through the part because they're either absorbed or they're scattered. Okay. So this is saying the percent of attenuation. So what percent photons basically are we losing in 10 centimeters of tissue at 50 kVp compared to 130 kVp? Okay. So if we had 1,000 photons, again, this is totally hypothetical, but if we had 1,000 photons at 50 kVp, we'd have about 99% of those photons being attenuated. Okay, it's a lot, right? At 130 kVp, we're going to have less. So about 94%, because at that higher kVp, overall, there's less chance of any interaction, right? As we said, at a higher kVp, there's a better chance they're just going to transmit through, no interaction. So look at the breakdown though of Compton versus photoelectric. And let's jump down, excuse me, let's wait just a second. So let's go down and you see how the percent of transmission went up with the higher kVp. That's what we're talking about there. Overall, there's a greater chance that the X-ray photons are just going to transmit through. However, when you look at the middle of this, chart, you can see that as kVp goes up, okay, so it goes from 50 to 130, Compton scatter percentage goes up because photoelectric goes way down, right? So it's more of the, and to not get so into your question, we're gonna get into that more, just not right now. Okay, and Ethan's going to get in that. He may have talked about this in 107? I don't know. Any 107 people? So I won't make you remember back to that. But anyway, so you can see that at 50 kVp, it's not a big difference between the percentage there of the interactions. But the higher kVp, there's going to be a better chance of Compton than there is photoelectric. That's when you look at them side by side. All right, so let's move on. We'll get into it. We still have one more week to review all of this, so that's the good news. Scatter. Increasing kVp increases the amount of scatter that reaches the IR because at higher kVps, the more forward in direction the scatter travels, therefore more has a chance of reaching the IR. So at higher kVps, not only is there a greater chance relative to photoelectric of a Compton interaction happening, at the higher the kVp, the more forward in direction that scattered photon is going to be, and the better chance it has of hitting the IR or making it to the IR, And so that's why we say, again, in general, if you have higher kVp, you're going to have more scatter reaching the ion. Just because I used to give an example. I don't know if this was a good example or not, but we'll try it. Let's try this. Okay. So think about if you had a brick wall, okay, and you have a tennis ball on a string, and you let the tennis ball go, it's going to hit the wall and do what? Bounce back, like completely change direction. But if I have a wrecking ball, and I always go straight to Miley Cyrus when I say that. If I have a wrecking ball and it's directed towards that wall, it's pretty much going to do what? Hit the wall and pretty much stay in the same direction. So think of that as the kVp. That higher kVp is going to have an interaction, but it's going to stay pretty much going in the same direction, rather than bouncing back and going off in a different direction, which would represent lower kVp. So this is in your Faber book, page 52. This is comparing photoelectric and Compton. This is a really good summary box. So I would say definitely read over this afterwards. Make sure that you understand the difference between the two. So the selection of kVp is very important. It is recommended that kVp levels not exceed 80 for any non-grid radiography, including the chest. So really and truly, with digital imaging, if you're going to use over 80 kVp, you really need to have a grid. So you either need to be doing it in the table bucky, the wall bucky, or using the clip-on type portable grid. Failure to use a grid with kVp greater than 80 is going to reduce your image contrast due to the amount of scatter that reaches the IR. So are you going to see this? People do this in clinic, use more than 80 kVp without a grid? Probably. A lot of times they can get by with that now because the software has built-in virtual grids. And so we'll talk about that next semester when we are really, really specifically talking about grids and grid use. But in general, it's a good rule of thumb that if you're going to use over 80 kVp, you really should be using a grid. Now, let's look at, mAs. So this should be becoming very easy to bring back because we've been talking about mAs for several weeks. We know that mAs is the quantity factor. So we use it to adjust receptor exposure because there is no change in the energy of the photon. So there's no change in attenuation. And this is an important statement. So highlight it, underline it, star it, whatever. When we say that, that means that there's no change in the percentage of penetration or photoelectric or Compton when we change mAs. It stays the same because mAs only affects quantity or number. It does not affect the quality of the beam. So changing the mAs doesn't change anything about the penetrating ability of the beam. It doesn't change anything about the subject contrast, distortion, recorded detail or spatial. It doesn't change any of that. It only affects receptor exposure. So that's why we like to use mAs to control receptor exposure. This again is a sort of a review of what we've already been talking about with kVp. It is the exposure factor that affects quality and quantity of the beam. So it affects quality and energy of the beam, but it also affects quantity, and that's what we're getting ready to discuss here. So the higher the energy of the electrons, meaning from cathode to anode, the more X-rays it can produce. The higher the energy of the X-ray photons means the increased penetration through the patient. And we have to take both of those things into consideration when we discuss the effect of how kVp changes exposure to the receptor. So we have to consider the fact that there's just more photons produced at higher kVps to begin with at the anode. And of those photons, they have higher energy. They have greater penetrating ability. So there's a greater chance that those photons are going to make it through and actually interact with the ion. So we have to look at both of those things when we're talking about changing how kVp changes receptor exposure. So if our goal is to maintain receptor exposure, which is what we did on the practical, right? We were trying to maintain receptor exposure with a change in what for the last practical? Distance. Yes. Our goal was to, can we keep the receptor exposure the same at this distance as this distance? Okay, that was our goal. Now our goal is going to be, okay, can we maintain receptor exposure when we make a change to kVp by adjusting our mAs? And so if the kVp is decreased, then we're going to need to increase our mAs. And if the kVp is increased, we're going to have to decrease our mAs. Okay, so what kind of relationship is that? Inverse. If kVp goes up, then if we're trying to maintain receptor exposure, we're going to cut our mAs down. And if kVp goes down, then we're going to increase our mAs to compensate. So let's talk about how much. All right, 15% rule. So here comes the math. Okay. If the kVp is changed by 15%, the mass is going to be changed by a factor of 2. Okay, so this means that if your kVp is increased by 15%, then you're going to cut your mass in half. If your kVp is decreased by 15%, then you're going to double your mass. All right, so that's not hard math. That's pretty easy math. It's just when you change kVp by 15%, your mass is going to change by a factor of 2. So it's going to depend on if you increase or decrease your kVp. Your mass is then either going to double or be cut in half. All right. So for example, if at 80 kVp and 5 mass, let's say that's optimal for a lateral skull. And that's actually, we're going to do a lateral skull today in lab. So let's say that 80 at 5 is optimal for a lateral skull. No grid. So we're still at 80 kVp. If we wanted to control motion, let's say that it's an elderly person in there, they don't know, they don't understand and can't hold still. Then we could, to get that mass lower, which means we could decrease our time, then we could increase our kVp 15% and do what to our mass? Cut it in half, right? Which in essence would mean we could cut our time in half, which would mean there would be less time for the patient to move during the exposure. Okay, so we increase our kVp 15%. How do you figure out 15%? You just multiply it by 0.15, right? So that's 12. So we add 12 to 80. That's where we get the 92. We did what to the 5? Cut it in half. And so we also can use 15% rule to make changes when we're adding barium. We will get into that more next semester. So there's also something called the rule of 10 kVp. And what it states is that if you are operating between the kVp range of 60 to 90, then 15% is about 10 kVp. So why do you think this would be an important thing to know? How do you think this is going to help you? Yes. He said it's quicker. Where does it matter if it's quicker? Huh? Yeah, like if you're in clinic, like when you're actually doing patients, right? So are you going to take time to say, okay, 80 times, which I know you haven't been in clinic yet, but you're going to see, right? You're not going to have time to sit there at the portable machine and do math, right? But you can add 10 and subtract 10, I hope, pretty quick, right? Pretty easy. So you could have said, all right, if we're operating between 60 and 90 kVp, see how what I've done here in this slide is I have actually shown you what 15% of those kVps are. Okay, so see how between 60 and 90, it's about 10 kVp. It's really close on the 70, right? Pretty close on the 60. So that's just a quick and easy way that you could do the math if you need to make an adjustment to kVp clinically. Okay, so the rule of 10 is just saying that between 60 and 90, 15%, that is about 10 kVp. Any questions about that? Okay. So, in summary, we want to use mAs to control receptor exposure because it doesn't affect anything else. It doesn't affect subject contrast. Now, there's a little caveat here that says, unless the change moves exposure into saturation, and then there is loss of contrast. So if you have used so much mass that you now have got saturation, which means you've lost information, you've lost data, that does reduce contrast. So we're not talking about that extreme. Okay, we're just talking about in general, changes to mass don't affect subject contrast because it doesn't change the quality of the beam. However, kVp does control subject contrast and it does affect receptor exposure. So we're going to use the 15% rule to avoid changes in receptor exposure if the subject contrast does need to be changed or if additional penetration is needed, say, for example, on an upper GI study, or rarely if we're trying to prevent motion. If we want to change kVp, how would we maintain receptor exposure? We would decrease kVp 15%. What that does is it reduces receptor exposure by about half. So what we'd have to do to compensate for that is double our mass to make up for that loss of receptor exposure that we're going to have when we decrease our kVp 15%. That combination of increasing the kVp 15% and decreasing the mass by 1/2 would do what? Maintain receptor exposure, which is our goal. I do want to go back for just a second to something because I was going to give y'all an example here and to help you understand. So when it says the higher the energy of the electrons, the more X-rays it can produce. So think about it this way. So what that statement is saying is in the X-ray tube itself, when the kVp is higher and those electrons are going from the cathode over to the anode and they have a greater energy, they are going to have a greater impact at the target than the lower energy photons would. So think about it like this. Let me make sure I say this right. So we have, let's go back to that brick wall. We have that brick wall and we have the same exact car. Okay, we have two cars that are identical. One of them goes and hits the wall rolling at like 20 miles an hour. And one of them hits the wall at 100 miles an hour. Which one is going to have more impact? The one that's going 100, right? There's going to be much more damage than that car that just sort of bumps that wall. You can also think of it this way. Let's say we have a 5-gallon bucket, okay, and we have water. And we have a rock of a certain size, okay? And we take the rock and we just sort of plop it into the bucket of water. It's going to make a splash. It's going to splash out. We're going to see some splashes, right? What if we take that same rock, same size rock, and we heave it into that bucket of water? What's going to happen? Which I always answers and she won't say it again, and I never hear because
Got it,
girl,
you got it.
it makes what?
Involved.
Yeah, it makes more splash, right? So basically, those electrons that are going at a higher speed, they're going to make more splash at the anode. It's gonna create more photons. Does everybody follow that train of thought? Okay, and then the second part of that is, okay, now those photons have higher energy. So there's gonna be a better chance that they're gonna what? You said it earlier. If they have higher energy, they're gonna have a better chance of doing what when they're directed at the patient? Penetrating through, making it to the IR without any interaction. So that's the why you have to change mass to maintain receptor exposure. So hear me now. You will see that question again. So star this slide, underline it, highlight it. If you want to get all the credit on the question that will be asked on the practical about, okay, why do you have to make the change that you make? This is the why. Because there's more photons, we're talking about higher kVp, there's more photons created to begin with, and of those photons, they have higher energy. There's a better chance they're going to make it through the patient's body and actually interact with the IR, right? And so the opposite would hold true. If they're lower energy photons, then there are going to be fewer that are actually created, and they're going to have less energy, so they're going to be less likely to make it through the through the patient to the eye. That makes sense? Okay. Any questions about, we're going to do activities today or this week in lab that are going to prove this and help it. We're going to use a dosimeter. We're going to see what our readouts are when we change kVp and mass, and we're going to look at EI numbers. So let me ask you this question, and then we're going to move on to looking at the last practical that we did in test 2. Oh, shoot. It went out of my brain. So I'm going to ask you. This is what happens when you get old. Like if you don't say it, that's why I blurt stuff out a lot of times, because if I don't, then I'll forget what I was going to say. Oh, well. It'll come to me. It'll come to me and I'll blurt it out whenever it does. All right, let's. And I'm going to stop the record.